Thank you for having me today. I will talk about something that is an issue for me every day. I'm an endocrine pathologist. I do diagnosis of thyroid cancer every day. I teach pathologists how to do diagnosis of thyroid disease all over Europe. And I think that this is a model that could really benefit from digital/computational tools. So if you have patients, I will put you under the setting. So diagnosis of thyroid cancer most of the times, fortunately, is the same of saying papillary thyroid carcinoma. So up to 80% we are getting the correct answer. So at this point, it should be easy. As the name says, papillary thyroid carcinoma, now will abbreviate to PTC, it does have a papillary architecture and also have this beautiful type of nuclei, which are enlarged, irregular, grooved, and with pseudo-inclusions sometimes. They're also clearer than the normal or benign ones. It happens that in the middle of the last century, a famous pathologist described that papillary thyroid carcinoma does not only appear as a papillary structure, but also as a follicular structure, as you can see there. The follicular structure is also the same structure of the benign lesions. So at this point, and for many years, the only morphological tool that we had to do the diagnosis of malignancy, reading PTC, were the nuclei. So these strange and beautiful and typical nuclei. When papillary thyroid carcinoma has this follicular structure, we call it the follicular variant. And this ancient study that united 10 experts in the field that evaluated 87 follicular variants of PTC, it reports that they didn't even reach 40% of concordance with respect of having this diagnosis. So relying on the nuclei, most of the times the expert cannot separate a benign from a malignant lesion. So you can see this is really a model that is worthwhile to explore. If you pay attention here, if you think about these nuclei, at least pathologists probably can say that the ones that are on my right side are quite typical, irregular, grooved, clarified. The ones on the left are more regular, more roundish, typical from benign, but those in the middle, it's a mixture, and then we just don't know. To put things even worse, in the last classification of the WHO, two major alterations came into the diagnosis of thyroid cancer. There was a downregulation of the importance of these nuclear features and an increased value in the signs of capsular and mainly vascular invasion. So again, stressing the importance of the invasive fronts as our previous speakers spoke about. This second part, I will just skip it. It's extremely important, but it will take another talk, so I will just keep with the nuclear features. What does this mean, downregulation? So at this point, we admit that these beautiful PTC-type nuclear features can be admitted in malignant, in papillary thyroid carcinoma, but also in a low-grade type of malignancy that was more or less recently described that are called the NIFT-Ps. So these NIFT-Ps are an everyday problem. They are everywhere in my desk, and they're impossible to manage because the differential diagnosis of this entity, it's very time-consuming. So this NIFT-P means non-invasive follicular thyroid neoplasm with papillary nuclear features. So it's non-invasive, it does have PTC-type nuclei, and also have this number of these 6 features that we need to exclude. So we need to make total inclusion of the capsule of the tumor and observe it. We need to make total inclusion of the tumor to see the pattern, quantify the pattern, quantify mitosis, quantify nuclear scoring, and all of these are measurements that could benefit from automatization. To keep this model even simpler, I can say to you that differential diagnosis between follicular pattern lesions, either benign, this low-grade new NIFT-P, and the follicular variant of malignant papillary thyroid carcinoma, does not have any clear-cut diagnostic tool, not even a molecular tool for differential diagnosis, and no validated digital tools, and very scant publication on the issue. Those that are in the literature, as I said, are very scant. Sometimes they use weird technology that cannot be reproduced in every lab, and they are restricted. So I decided to play a bit with this, me and my colleagues. We started with a study of the concordance between the digital and the optical diagnosis of Thyroid pathology. And this has been done before, as it was in other models, but at this time, we decided to do something a bit different. So we used 50 slides from 48 patients, and I included these types of pathology. So adenomatous goiter, which is benign, thyroiditis, which is inflammation, it's also benign, these low-grade NIFT-Ps, papillary thyroid carcinomas, and other types of carcinomas, follicular/oncocytic carcinomas, that are now different, but they are of the same family of tumors. These slides were transformed in whole slide images, and then I asked 5 pathologists to make observation, diagnosis, and measurements. I didn't tell them that these were the categories, so they could say whatever they wanted. And then, 10 days after, at least 10 days after, they observed again, but this time using the microscope. First time using digital, second time using microscope. So the other way around as it used to be done. So what we realized that concerning time, we have here 2 situations. We have here the pathologists, P1, 2, 3, 4, and 5. The P1 and 2 are more experienced ones. So they are doing a digital diagnosis for more than 5 years, and the others have occasional contact with the digital images. And we realized that in this exercise, the pathologists with more experience on digital diagnosis took less time per case than the less experienced one. The problem was that we also realized that they were also the fastest in the optical setting. And the additional mean time they needed to do diagnosis was not that different from the colleagues with less experience. This is a bit different from what we observed in other studies. I don't know what to say about this. To be optimistical, I think these 2 guys trained a lot in digital, and they also trained themselves to be faster. And this was, again, that was explicit in both situations, but I'm inventing. So let's moving on. Then we also asked these 5 pathologists to do measurements, just for staging purposes, which is something that we do every day. So to measure tumor size and the distance of the tumor to the nearest surgical margin. And the results were pretty clear. A correlation study that compared all pairs of pathologists showed us that the digital evaluation was much, much better. The worst result, the worst pair on the digital evaluation was better than the better of the optical evaluation. So the digital measurements of the tumor size are more reproducible than the optical ones. If we correlate these evaluations of tumor size, when we compare in a single pathologist the digital measurement and the optical measurement, we can see that sometimes they are very consistent. So there are pathologists that measure things very well in both settings, and there are those that are very lousy. And I can say this easily because I'm the P1, so I was the lousy one in this job. So the concordance here was not bad, but it was not perfect. Now concerning the distance of the tumor in relation with the surgical margins. This is a very important point because it says if the surgery was complete or not. And here again the results are the same. The digital evaluation is much more reproducible than the optical one. Here again the concordance between optical and digital evaluation for each pathologist can be very good, but again can be very bad. And I believe that these poor results or less good results are related to something. When we do the evaluation of the tumor size, we can even do like this. We look at the window, we put the slide, and we can easily see in low magnification the borders of the tumor. But when concerns the evaluation of the tumor margins, we need to see if that margin is really a margin and not just a cut in the macroscopy in low power, to see if there's there's some signal of intervention there. And that can be a problem. We need to go high magnification, low magnification, and to try to put all things together. And now, what we are expecting, diagnostic concordancy. We try to establish a ground truth, and here the diagnosis of the majority of the pathologists that was coincident with the P1 pattern, by the way, in the optical diagnosis, was established. So the pathologist optical result was the pattern. And we realized that pathologists really don't agree. It's not that bad when we compare with the 40% that was achieved before in the other study that I showed you before. The pathologists that concord less with the pattern had 66% of concordance in the optical. But if you take a look at the digital performance, it's amazing, it's better. I cannot say for sure the reason of this, but digital diagnosis allow an increase in the concordance with the pattern among pathologists. And this, in the setting of thyroid pathology, could make the difference. You know, there are many trainees all around the world that spend a huge amount of time just training their eyes to see, this is PTC nuclei, this is not, this is not. So this could be a tool that could help pathologists to become more concordant. We also appreciated some things more. The major reason of discordance with the ground truth in the optical diagnosis was the nuclei. By the way, in all settings were the nuclei as expected. And in the setting of the optical diagnosis, pathologists tend to discord overestimating the nuclei, so making more often the diagnosis of malignancy. On the other way around, in the digital settings, they tend to do the diagnosis they tend to make a benign diagnosis more often. So it's in the opposite direction. And again, probably this is related to the magnification. If you don't go to very high magnification, you miss or you underestimate, which is not necessarily that bad because you can see here they become more concordant. Importantly, there was no overestimation of invasion in this digital use of digital diagnosis. The major reason for discordant, inter-observer, was again the nuclei and for underestimation again. Then we decided to do another thing. We realized that for NIFT-P diagnosis we need to have a nuclear grading, which is something new in thyroid. We don't like it. It's an extra work that we have to do, this type of evaluation. So I decided to do some morphometric studies and see the other way around. So if the computer was concordant with what the pathologists are observing, okay? And we used the same whole slide images. We captured pictures, some of the cases with one picture, some with two pictures, and then we collected 61 lesions and millions of nuclei to analyze. I decided to use the QPath, and what I realized was this. So I will try to explain you briefly what we are seeing here. So in that side, you're seeing a picture of a benign lesion, an adenomatous goiter. See, the nuclei are round, are dark, are very regular. This side, you're seeing typical PTC type nuclei. They're irregular, they're squared, they're clearer than the other ones, and they have something that can really be a problem in this analysis. They're overlapping a lot. So in this study, I started with the area, and in the graphic, you can see the AG, the adenomatous goiter, which is benign, thyroiditis, which is also benign, follicular carcinoma, those low-grade NIFT-Ps and PTC. What we know about these nuclei, it does fit with this distribution. So the small ones are the benign. Afterwards, you have the thyroiditis, which are also benign. And here, we know that sometimes it's hard to distinguish papillary thyroid nuclei from those that we found in thyroiditis because they are larger. And here, they are a bit distant concerning the area. I think here, we had problems in separating epithelial cells from lymphocytes, which are smaller, and then decreased the area, the mean area of the nuclei that we identified in this lesions. Then we had another problem here. NIFT-Ps and PTCs, by concept, they have more or less the same type of nuclei. And we realized here that those in the NIFT-P appear to be larger in this analysis. And it doesn't make sense. Or they are similar, or they are smaller. By our eyes, I mean. So I'm trying to compare what we have as a concept. And this, I believe I can explain by the same problem that I found in the examination of the perimeter. Because these nuclei are very irregular and very overlapping, when I see the contours of the nuclei that the program makes selecting the nuclei, they are not complete. They're not all around. So they are underestimating the area and probably also the perimeter of these lesions. Here in the perimeter you can see that again in the NIFT-P and PTC categories they are not so distant and they are in the other way around when we think based on the pathologist observation. Nevertheless, they are very important, apparently they are very important tools because they can separate clearly these types of nuclei. Then circularity. I put some pictures there for you to imagine how it looks in histology. So the more circular are the more benign ones, and the more irregular are the more malignant ones in size of the PTC. Okay, I'm trying to ignore a bit the follicular carcinoma that is in the middle. And you can see there that although statistically different, the nuclei in the follicular pattern lesions that are in the middle are very close to each other. So probably circularity could be something that we could use as a very good tool in the setting of cytology. But again, this needs some further experiments. I like this one very much, solidity. So we know that papillary carcinoma nuclei are more clear, so are less solid, so to say. And this is very evident here. They are quite separated, the benign and the PTC type nuclei. You can see there in higher magnification how different they look and how good they are separated in the analysis. Here, unfortunately, this scoring will not be useful in cytology because this is an artifact. This clearing, it's an artifact of histology. It can be also a problem if we think about staining artifacts. This is much more sensitive to those fluctuations. Again, it's useless also in types of PTC because there are many types of PTC. So diagnosis of thyroid cancer is not that easy that I'm trying to convince you. And PTCs with dark type nuclei are also escaping from this model. Another thing that I tried to do was to see if the program was sensitive to such a thing called pseudo-inclusions. It's a bit of cytoplasm that enters the nuclei and looks like a round dot inside the nuclei. And as these features I were analyzing were not showing anything, I just tried to analyze one nuclei with pseudo-inclusion and one nuclei without pseudo-inclusion. Well, this is just as simple as say, and the features, the results of the features were the same. So apparently, this is not detected by this type of analysis. And in the setting of histology, it's not important, but in cytology, it is. The results that we found here, they look very promising. Using the nuclei to separate benign from malignant can have a really value in grading the nuclei and can be in optimal conditions contributive to do this grading. I would like to add another thing here. Nobody cares about the normal tissue, the normal pattern. And here, I tried to compare these nuclear features here. I choose the area to separate the benign nuclei from the normal ones. And this in histology, it really doesn't matter. Why? We don't care. We can see this in low power, in high magnification. The architecture can say to us it's benign or it's malignant, or if it's benign or if it's normal. If it's benign or if it's normal. But in the setting of cytology, this does not happen. In preoperative diagnosis, if you have scant material with small dark nuclei, we don't know if you are puncturing the nodule or outside the nodule. The appearance is the same, and that's the reason why we have strict criteria for adequacy of sampling when which concerns cytology of thyroid nodules. And you realize here that the area, it's a very good tool to separate these ones, okay? So in conclusions, the digital diagnosis takes more time than optical diagnosis in this rudimentary study that we conducted. The digital measurements are much more reproducible than the optical ones. The digital diagnosis allow increase in concordance with a pattern among pathologists, and the nuclear features are still the most frequent source of discordance in both models. Apparently, the digital nuclear features of thyroid lesions are not linearly correlated of what we think the nuclei look like in the optical setting. Determination of the mean nuclear area and perimeter are valuable tools that, after validation, could really help us in the nuclear grading. And the exploration of the capacity to distinguish normal from benign can really change the way we consider the adequacy of sampling in cytology setting. Now I have 3 provocative slides for people from the IT area in the audience. First, please consider to include in your studies the analysis of the nuclear features of thyroid lesions. Maybe with further characterization, we can give back the nuclei the importance they deserve, and we can help cytology to recover a bit of their predictive value. Then another thing, it's the analysis of the invasive fronts. It's being an exhaustive work to do this. It's quite expensive, it's taking much of our time, and it's quite important to see what is happening at the periphery of the tumors. We have to do total inclusions, complete observations, very exhaustive work. And maybe we can find a tool to accelerate these peripheries. Can we accelerate the evaluation of invasion? And finally, it wouldn't be wonderful to give further information at the time of diagnosis, of course. Although we don't have any diagnostic molecular tool for differential diagnosis in the most frequent thyroid cancers, we have molecular markers that predict outcome and that are markers predictive of the response to therapy. And that would be wonderful to report at the time of diagnosis. Here I thank to my team, the pathologist team. We were 5 observing these cases, Polonian, Sofia, both Portuguese like me, Ayat from Jordania, Nusayba from Kuwait, and then our technical team that helped a lot. Just to remember, don't forget, next year, see you in Porto. Thank you.
Thank you, Catarina. Any questions? So one thing that sort of strikes me, I was looking for literature, and there's hardly any machine learning or AI work on thyroids. And is it because it's impossible to do? I mean, the sense of pathologists can't even agree, so just to get the ground truth seems like quite a difficult task.
As far as I know, there's no complex work. I saw today in the poster session a work that was, giving some light on a parallel issue on thyroid, but as far as I know, unfortunately not.
Given the difference in nuclear morphology, I'm quite surprised that there aren't differences in markers, cell proliferation markers, cell cycle markers.
No, not at all.
Which is quite strange because that morphology is quite distinctive, isn't it?
Yes,
it's from the solidity and circularity.
It's the only cancer model that does have this particularity. If you think about mitotic index, for instance, or any type of marker of proliferation, you'll have it the other way around because papillary thyroid carcinoma is an immortal cancer. So what you find more frequently is 1-2 mitoses in a whole slide. On the other hand, you can have 5 or 7 in a benign lesion. So it's nothing to be correlated. It's more frequent to find mitosis in benign nodules of patients that are going under treatment, endocrine treatment, than in tumors. Okay, here doing a simplistic approach. So these are the most frequent. If we are talking about an aplastic thyroid carcinoma, which is a very rare and lethal tumor, you can have about 20 mitosis per 10 high power field. So it's a distinct reality, but a very small setting. I'm just talking about the most frequent ones.